Welcome back to the afternoon session on pricing in healthcare. Um, I'm just going to set up the basic question on what we're going to be discussing and how we're going to proceed. So we have three main speakers over here. Each of them will be offering an opening remark around 8 to 10 minutes, and then followed with that, I'll open it up for Q&A to the rest of the room. But as I was just telling them, they don't have to stick to 8-minute monologue. If they don't want to, if they want to have back and forth, that's perfectly fine too, because that might be a little bit more interactive and people might enjoy that more as well. But the main setup for this particular policy session on pricing in healthcare is that we'll explore two domains where high prices have triggered sustained concern and regulatory attention. One, we're going to talk about hospital billing practices in the US, and the second, we're going to focus again on drug pricing in the UK and EU. At the heart of this discussion is one underlying central question, but what is the role of competition policy in addressing pricing practices that appear excessive or unfair, especially in sectors as distorted and complex as healthcare? So we're going to start with first the hospital side. The basic premise or setup over here is that in the US, there has been something called surprise billing. Of course, Marty will tell us more about it, but the initial point over here is that patients receive unexpected, often out-of-network charges for care they may have received under emergency care or something like that. And this has long highlighted the deep failures in the market functioning. There was a regulation that was passed or an act that was passed, No Surprises Act, which curbed many of these billing practices. Broader issues still persist. For instance, there's opaque pricing, there's strategic use of billing codes, which is called DRG creep and things like that, and facility fees. And there are complex insurer-provider dynamics that often shift the bargaining leverages and not necessarily improve efficiency. So these practices raise important questions for competition policies. Are these failures the result of anti-competitive behavior, or are they structural features that require regulatory but not necessarily antitrust solutions? And for this part, we'll begin with Marty, who will share insights on medical billing, market design, how the current system may be distorting incentives in ways that antitrust alone may not be able to fix it. Then we'll try to turn to drug pricing, focus mostly on Europe and UK, but feel free to bring in US context if you want to as well. Here we've had authorities have used excessive pricing rules to target or sharpen price hikes in off-patent drugs. Most notably, we heard today from one of the speakers, Miroslava, on the Pfizer-Flynn case, for instance, in detail. These cases rely on what's called the United Brands Test, which has two key questions that it asks in order to understand about the excessive pricing. One is the price excessive relative to cost and a reasonable return? And if so, is it unfair? And the unfair itself is also in two parts, either in of itself or compared to some other comparator group. The legal standard on this is very clear, but its application is not. We heard the Pfizer-Flynn thing this afternoon. The CMS initial findings were overturned because the tribunal found its reasoning on fairness and economic value insufficient. It went back to the tribunal second time after CMA gave the second decision. And again, that time, CAT turned it down and gave their own decision, somewhat similar to CMA's fines, but for different reasons. So eventually, the CAT upheld the excessive pricing arm, but only after conducting its own economic assessment and adjusting the framework for how to evaluate fairness. So both areas, surprise billing and drug pricing, raise the same core issue. When is a high price a competition problem, and when is a system of market that needs better rules? I'll hand it over to Marty to take on first. Mart?
Thanks, Farasat. So first, let me say, before talking about billing problems in the U.S. with regard to the hospital sector, this really applies to healthcare quite broadly in the U.S., there is a very major problem with market power and the exercise of market power in hospitals and healthcare in the United States. Now, when this happens as a result of mergers or anti-competitive conduct, monopolization, things like that, that certainly does fall under the U.S. antitrust laws and can be pursued by competition enforcement, competition policy. So that's actually a very, very large problem and an issue in healthcare in the U.S. However, it's not related to the billing problem that we were talking about in any direct way. So let's talk about billing. But I think it's important to know that as a backdrop. Actually, the vast bulk of the pricing problems in the U.S. are due to pervasive market power in healthcare, and those are things that can be addressed in most cases by competition enforcement. So billing, I want to talk about surprise billing and general issues with medical billing in the U.S. context generally. So what is surprise billing? This is for patients in the United States who have private health insurance. Private health insurance companies have what's called a network of providers, hospitals, doctors, other kinds of providers of medical services. They have negotiated price arrangements and other aspects of these arrangements with these specific providers. If you have health insurance through this company, you go to an in-network provider, there's an agreed upon price that they will get paid, and the patient will pay an agreed upon amount as part of that. If you go to a provider, hospital, doctor, who is not in your health insurer's network, they can charge you anything they want. They are not bound by any agreement because they have no such agreement. Now, of course, if you know ex ante who's in and who's out of your network, and you can exercise choice, you have that information, you can choose to go to an in-network or an out-of-network provider and make a fully informed decision. Someone might choose to go to a provider who is not in their network and pay more because they think it's worth it to them. However, here's what was happening with surprise billing. This most commonly happened in situations where the patient had no way in advance to know whether they would be seeing a healthcare provider who was in their insurer's network and therefore under contract with their health insurer. Here's an example. Suppose somebody has an emergency situation. They go to the emergency department of a hospital. That hospital is in network with their health insurer. All right? So they know that. The emergency medicine physicians who staff that department, in many cases it turned out, were not in network with the health insurer. The patient had no way to know that in advance. So they go, they get treated for this emergency situation. The hospital bill is at the agreed upon arrangement with the health insurer. However, the physician bill or physician bills with this out-of-network emergency medicine physician practice are not. And so patients would unexpectedly get a very large bill, and they would have to pay the whole thing because there was no arrangement with their health insurer. There's no way they could have anticipated this in advance. This started happening in the following way. Private firms, private equity firms, started managing these private physician practices specializing in emergency medicine. And they discovered that they could do this. So it was a profit opportunity. This is not illegal, by the way. And there might actually have been a situation where there were plenty of emergency medicine physician practices around. So in principle, there could be competition. But of course, since patients could not know in advance who was in network and who was not in network, they could not make an informed choice. This is literally an emergency situation. So this became quite pervasive. Another scenario which occurred, very common, is where a patient would have a procedure in the hospital would be in network, and say the physician performing the surgery, the surgeon would be in network, but would turn out the anesthesiologist was not in network. Who would think to ask in advance, oh, is the anesthesiologist going to be in network? Or pathologist, will there be a pathologist involved? Well, for many medical procedures, it depends on what the procedure is, and they don't even know whether they'll find something during the procedure for which they would involve a pathologist. So this was the scenario under which this was happening. Patients were getting socked with these bills. They could not make good decisions, and if people can't be informed and they can't make good decisions, the market can't function, right? This is like economics 1.
Yossi has a question.
Yeah, Yossi.
Why is it even legal for the hospital to employ people out of network without, like, you know?
Right. So this is an idiosyncrasy of the system. The physician practices, say emergency medicine physicians, they're not employees of the hospital. They have an affiliation. There are very, very few physicians who are actually employed by the hospital. So they are an independent firm, but they have an affiliation with the hospital. Now, you could still ask, why would the hospital want to be affiliated with a practice that was doing these kinds of things? So that kicks the can down the road a little bit. But the fact is that it was happening, and once it became pervasive, hospitals perhaps didn't have any good alternatives if all emergency medicine practices were doing these things. So they didn't have direct control other than they could say to an emergency medicine practice, we don't want to be affiliated with you anymore, but then they would have to find some other practice for that purpose. So that was what was happening. That's not a competition enforcement issue. Typically, the U.S. antitrust laws, Russ can correct me on this or others if I'm wrong, but there's no abuse of dominance aspect. U.S. antitrust laws, there's no excessive pricing aspect to U.S. antitrust laws. So like I said, if you had a situation where there were enough emergency medicine physician practices for there to be competition among them, in principle, it's not obviously a competition enforcement problem, but when consumers don't have information, they can be taken advantage of and rents can be expropriated from them, even if in principle there are lots of other places they could go. So what happened was, as Farasat mentioned, there was a law passed by the US Congress called the No Surprises Act, which basically made this sort of thing illegal. So it did put a stop to this for the most part. It's turned out in practice that the way it was implemented is if there's a dispute, a patient can protest, it then goes to arbitration, and the arbitrator decides what is the amount that should be paid. The practices, the firms engaging in this practice, it turns out empirically, often get paid a price very close to the original amount that they charge somebody in arbitration. But after the No Surprises Act, health insurance companies pay that, not individuals. So it still comes out of somebody's pocket, but not the individual patient anymore. So that got dealt with partially, but this is a competition policy as opposed to, I think, a competition enforcement issue. And this is where you have a very severe asymmetry of information that only gets resolved ex post, not ex ante or even at the time of. So something to think about there is whether there can be more effective policy that permits this market to work. Then, of course, there might actually be violations of antitrust laws one way or another, but you don't even have a situation where the market can work. Now, more generally speaking, medical billing in the United States is just a horrible, messy situation. So people who have private health insurance will get bills if, for example, somebody goes for a very ordinary diagnostic procedure, say a colonoscopy, very common diagnostic procedure. If that is done in a hospital outpatient facility, there will be one bill from the hospital. There'll be another bill from the gastroenterologist. There'll be another bill from the anesthesiologist. Some cases, there's more than one anesthesiologist. If they find a polyp and send it off to be analyzed during the procedure, there'll be a bill from a pathologist. All those different bills, and in all kinds of things happen. First off, these bills are often complicated and very difficult to understand. There are inaccuracies or mistakes in them. There are duplicate bills. I myself can say there have been situations where I've gotten 3 separate bills for the same thing. One in the mail, one via email, and one via text. In none of those did they say, this is just the bill for the same thing. You're going to get it 3 different ways. So I easily could have paid 3 times for the same thing, and then I would have had to try and recoup the amount I'd overpaid from that, and good luck with that. So the list goes on and on. Now, what's my point here? People don't know what things cost. They don't have any good way to judge what they're going to cost. Markets can't function adequately. Part of this has to do with the market for healthcare services, but it also has to do with the market for health insurance. So people don't know, for example, if they get duplicate bills, if they get bad bills, if they get incorrect bills, what will the health insurance company do? What will the health insurance company do if you get a surprise bill? Well, if you don't know that, how can you choose among health insurance companies? And then why should any health insurance company bother trying to do a good job helping its enrollees on these issues? If anything, that's a money loser, right? Because people who are choosing among health insurance companies have no idea who does a good job helping enrollees with medical bills. Well, that costs money. And if you don't reap any reward in terms of getting more enrollment because you do a good job, it's all cost and no revenue. So this is a very general problem. Again, it's not really an enforcement problem, at least under US law as I understand it. I'm not a lawyer. I don't even play one on TV, but my understanding, but it is a very big policy issue. So I've just described, hopefully not at too great length, but I wanted to give you a little sense with the American system, which I know is not familiar to most people.
Thank you, Marty. That was wonderful. We're going to move to the next one, but before we do, there's one question over here, and I can't help saying, I think you're basically telling us that there should be one big, beautiful bill?
Oh, please, don't paraphrase he who shall not be named.
Right here. There's a question here from Marty.
Thank you for your presentation. It was very interesting. So this is my question. Why, in the case that you just described, this case of asymmetry of information, it seems that the US law doesn't take into account the fact that the patient is the weak party here, and that, you know, basically it looks like a shakedown of a person who is about to go and have an operation, and of course he's not in the state of double checking whether this doctor works for the hospital or not. So it looks like something really, really strange. I know that you mentioned there was a reform, there was a law adopted, but still it doesn't seem to live up to what should be done in this case.
Did you hear the question?
No. Sorry, could you repeat the question?
I'm sorry, the audio is not real good. I
I think
apologize.
his point was, it doesn't sound like the,
No.
Did you understand the question?
yeah, that the law did not, even though there was a law passed, you still have a patient who's in a very weak position and is being shaken down.
Yeah, yes. After the law was passed, though, the big difference is that even though this behavior, surprise billing, does continue to some degree, the health insurance company ends up paying it, not the patient. So it goes into total expense, and of course, that shows up in premiums, health insurance premiums. But say, if I went to the emergency room and the emergency medicine practice was out of network and there was a gigantic bill, prior to this law, I very well may have had to pay or at least dispute with that. Now, it goes to arbitration. Arbitration makes a decision, and it's between the health insurance company and the medical practice. As a patient, I don't get involved. So my life is better in that regard.
I'd like to move on to Margaret, because we're going to otherwise lose all the time.
Okay, so I'll talk about excessive drug prices, which I think has a number of different structural sources that are different from the hospital situation that we just heard about. And I think actually the variety of different structural problems that can lead to excessive pricing is important to bear in mind. So one reason that excessive pricing can take place is because there's collusion. And there have been examples of that in the US. And there, of course, it's appropriate for competition authorities to enforce the law. That seems quite straightforward. There are other situations where you see a price spike because of a shortage. So a manufacturer has been hit with a manufacturing violation or has decided to exit the market, and whoever is left takes the opportunity to raise prices. And it becomes tempting, and even though at the national level there isn't an excessive pricing law in the US, there are, I think, at the state level in some places. And it becomes tempting to say, okay, we need to enforce this, we need to come in and stop that behavior. The problem is that we actually want that price signal to go out to the market to encourage entrance so that we don't have a fragile supply situation in the future. In the case of drugs, the challenge is that it's not like it's instantaneous that somebody else can hop into the market right away. And I think one example of a regulatory fix on the US side that was a good idea some years ago was Scott Gottlieb, when he was at the FDA, said, okay, we're going to try and identify the generic markets where supply looks fragile, where there aren't a lot of entrants or there are not many approved manufacturers. And we want to prioritize the entry applications in those areas so that we have manufacturers who are ready to go online and start manufacturing right away if there's a shortage and the price goes up. That strikes me as a better solution than trying to do a Band-Aid fix ex post or wield excessive pricing laws in a clumsy way. On the European side or UK side, for example, Pfizer-Flynn, that was, for me, a very clear case of firms figuring out how to exploit regulatory barriers or regulatory idiosyncrasies in how prices are set. And it's much better to just fix that problem rather than use excessive pricing to go after it. Because then, as you heard earlier today, the United Brands test and all of this, it's really not that straightforward to apply in practice. So I think, my view would be you look for the structural problem rather than use excessive pricing laws. Sometimes that's something competition policy can address, but often it is a discussion with the regulator about the barriers that we should be working on. Pierre?
I agree with what you said. So I don't have much to add. So I was planning to say a few words on shortages also. And I think that's what you said, Margaret, is a very good point. So in many European countries, including France, the price of generics is regulated. So you don't even have the hope that a price increase will solve the shortage. So basically, you have shortages. And what we have done recently, which I don't think is going to fix the problem, is to put fines on the industries when they are not able to supply. I don't think that's the right solution either, because this is going to basically incentivize some generic companies not to even enter the market because they know it's too risky and the margins are small and the risk of fine is really important in case of shortages. So yeah, so there are regulatory solutions to this. They are not easy. So I don't think the US model is perfect. I don't think the French one is either perfect. So we need to find, and I think economists can play a role, we need to find new regulations to avoid those shortages. So some price regulations with some sort of commitments of supply, which could be a solution. So where you're not going to have excessive pricing because the prices are regulated, but you're also trying to enforce guarantee of supply. So that's that was what I could say on shortages. I think we have a big problem in Europe also, which is the fact that, I mean, Margaret was talking about it in her presentation. We have pricing that are national. So you have 25 countries that all have different prices, different price regulations. Some regulate the price of generics, others don't. And that's really complicated. That makes things complex, given there is parallel trade within the European area. And I think we need, in the pharmaceutical legislation, they talk about a lot of things, but not about prices. And so that's also something we need to improve, but we don't have yet a solution to that.
Well, so on that point, let me, as we discussed earlier, I think there is a case that the prices should be different across countries. I think that's price discrimination that probably improves access. The problem in Europe is trying to play it both ways, to say we're going to have health as a national competence and pricing is going to be at the national level. Oh, but we're also going to refer to each other's prices and we're going to have parallel trade. That doesn't, I mean, that's just incoherent.
Yeah.
And we're going to prosecute someone when they try to stop the parallel trade.
Yeah.
To go on.
So, on this, I think that is a problem in European policy, this disconnect or this lack of coherence between the desire for a single market, but then also wanting national control over a lot of aspects of healthcare in particular.
Yeah, so I'll certainly agree with that. And that, even though, of course, the U.S. is absolutely a gigantic market, it plays out as well. So that yet again, there's talk about reference pricing in the U.S. by he who shall not be named. And that is without, sorry for the pun, any reference to what's happening elsewhere or coherent thought about what might happen. And this does, I think, come back to some of the comments I made earlier in the keynote about thinking clearly and consistently about policy in a coherent way and communicating about that. I also want to emphasize something, Margaret, you just said a few moments ago. Competition enforcement is, of course, important, but as a former competition enforcer, we're like the police. We're the competition police. We often come up when something bad is about to happen, or even worse, has already happened. Far better to change the rules of the road or the design of the road in some way so that competition is far more likely to happen and work and be effective, so that enforcers are not needed or not needed nearly as much. So I think that careful thinking about policy really should precede thinking about enforcement. So hopefully we have far less need for enforcement at all.
Okay, thank you very much. I think I'm going to open up the floor to questions. Please go ahead. Yeah.
Can I ask something? I'm hearing. Sorry, can you hear me now?
Yes.
I'm hearing that regulation can be a blunt instrument. I would like to know from the panel if we're talking about altering the configuration of markets through regulation, how information asymmetries might be overcome. Is this something that we're going to have to live with? Can we actually deal with it? Because as I see it, there's an awful lot of discussion currently about enforcement. Enforcement's good, but that's a bit late. But the flip side of that is that changing regulatory structures and markets in particular will only work potentially if you have sufficient knowledge. And that's a problem for agencies.
Before you answer this, may I suggest that we take at least collect 3 questions, because we're going to otherwise run out of time.
If you think you're going to remember,
So
I won't.
there's a second one here, and there's a third one. Okay, go ahead.
information.
Okay, sorry. So we are discussing excessive pricing. I wonder if you think about there being excessive cost due to compliance with bad regulation, or do you think that that's fine?
We'll take that as the second question. Then, is it excessive cost problem, he's saying?
So I wanted to get back to some point on excessive pricing, because I was a little bit surprised that the only thing that was being said is that prices going up might be good because it might lead to entry. Because one of the reasons why we have a competitive system is also when things get scarce, the price goes up in order to better ration instead of a rationing, mere quantity rationing system. And my question in that context is, probably prices should be allowed to go up. What are the circumstances in which we don't want a high price response? Or in what circumstances do we actually want different rationing than that which is given through the pricing system, which in principle would be efficient? Especially because short-run shocks, where prices are going to go up because of short-run shortages, we're always going to have. And those are the things that are discussed as price gouging now very often. So I'd love to get a response to that.
I'll respond to the question one about information asymmetry. So I think here one has to think carefully about the nature of the information asymmetry to the extent that not just it can be reduced, but that patients can act on that in a meaningful and coherent way. And I think that's a real challenge in healthcare. So here's, I think probably one of the more extreme examples. Consider emergency care. Patients could be well informed, but what difference is it going to make, right? So there, I think one can't rely on rational, informed decision-making by patients in situations like that, where people have more time. In principle, you could see that, but we actually have a fair amount of evidence for the U.S. where people say can choose where to go for a scan, an MRI, not an emergency. Their health is not in any particular danger immediately. They're given information, and they simply go to whichever place was recommended by their doctor, even if there's another place that's cheaper and closer. So it's not clear we're going to see meaningful action based on that. And so then I think we have to think about sort of more third-party entities acting to try and get us to a situation where it overcomes that problem. And this example of surprise billing, again, I think is an extreme example that epitomizes the nature of that problem. But that's just an extreme example. There are more run-of-the-mill problems that abound in healthcare. I'll just say one last thing about that. Let me be clear, obviously, I'm giving you my opinion on this. There are some in the United States that think, build it and they will come, just give people relevant information, and next thing you know, it'll be like buying a quart of milk or getting a gallon of petrol or something like that. I don't hold like that. I think that's very unrealistic. But there were initiatives under the first administration of he who shall not be named, and perhaps continuing in this one, for, say, price transparency for hospitals. The notion that patients would somehow find those prices and act on them and drive the market the way they might in a market for paper clips or pencils, I think is totally unrealistic. And so we have to think about other kinds of alternatives for disciplining the market, driving providers in a way that we end up in a place that is beneficial to society.
Margaret, if you want to answer one of the other two questions, and then Pierre, you.
So I think if we have a problem of insufficient supply and we're not going to try and resolve the problem through a price signal to encourage new entry, and as I said, I don't want to suggest that that always works because there are these barriers to entry. So we should make sure that we reduce a lot of the barriers to entry so that at least the entry could be quicker. Then we need to explore other ways for those who are procuring these risky supplies to encourage them to plan ahead for this kind of variability. So have second sources, et cetera. But, and I think there are some markets in where the governments do that in a more competent way, rather than, I mean, as Pierre was saying, in France, if you just fix the price, then we're not, that's not going to take care of the issue. But it probably requires a bunch of tools. It's not like just streamlining generic entry is going to take care of all the price variability or price fluctuations that might happen. But I think at least that's a step in the right direction. And I am concerned about the French approach or the use of excessive pricing cases that discourage firms from exercising the flexibility that sometimes they need.
Yeah, I just wanted to add a remark on the price transparency issue in the European context. So in the European context, we are not talking about patients being informed of what they are going to do, because basically they're covered, and we are more talking about the regulators negotiating in the best way the price of drugs. There are discussions about whether price transparencies within the European Economic Area would be good or not for this price negotiation, because there are list prices that are totally known, but we know that there are national rebates. We have rebates in France. There are different rebates in other countries. Those rebates are totally confidential. And some call for transparency of rebates so that the net price be public and be transparent to everybody, so that the negotiation could act. It's not totally clear this would be good. So I think it's still a question mark whether this would be good for Europe to have price transparency. And the reason is very simple, but basically it's very likely you end up with a unique price. And as Margaret said before, I'm not sure we want a unique price within the European Economic Area. There are some poorer countries, there are some countries that need less of some drugs than others, and you may want to let each country decide whether they are willing to pay higher price than others on some drugs. So that's a difficult question, because we also see the disadvantage of non-transparency, but that's something we need to work on.
Well, one thing that does come up in discussions of price transparency generally in sort of all sectors of the economy, not just pharmaceuticals or healthcare, has to do with whether that might facilitate collusion, right? And there's the famous research piece about Danish cement, right? The authors of that piece became very unexpectedly famous because a New York Times reporter found out about a research study and wrote about it. So that is an issue that does arise and also has to be considered. So that is a competition, or potentially a competition enforcement issue. I'll just return to the information asymmetry briefly. In the U.S., sort of the way this has evolved, again, I don't think it was by design. The way it's evolved is that patients are really not capable of shopping on their own, and that probably seems self-evident to most people. So what has happened is private health insurance companies, in a sense, do that for them, right? They negotiate with doctors, hospitals, whatever, and the idea is they sign up this network, as I addressed before, of healthcare providers that give them a good price and also hopefully meet other kinds of criteria, like good quality and locations that are reasonably convenient for their enrollees. And that's the bargain that's been made. Now, the way that it can work, to the extent anyone has given thought to this, is if health insurance markets are reasonably competitive, then people can choose among health insurers based on how good a job the health insurers do at this thing, which brings me back to, if people don't have good information about what their health insurer might do or could do, and this is the medical billing problem writ large, that's only one aspect of it. People have no idea ex ante, they can't make good choices based on that, and they can't drive the market. At which point, some might think, well, why don't we just head straight to Go, collect $200, and have a single-payer system with administered prices? But that's not likely to happen in the United States anytime, probably within my lifetime, I would guess.
Thank you very much. I'm sorry, I'm going to have to close the session because I'm being told we are over time. Okay, one last question.
I
and then
talked
we'll
too
go-
long.
Yeah,
I'm sorry.
yeah. Go ahead, one last question, and then we'll close the session.
Just complementing Marty's point about the ability of hospitals or medical insurers to do the policing themselves, one thing you haven't mentioned, which I think has been I'm not an expert on this, I think a failure of the competition law enforcement in the US is this business of private equity slowly buying up the anesthesiologists, the OBGYNs or whatever at the state level. And in the most recent merger guidelines issued by DOJ and FTC, that's one of the things they emphasize is these small mergers can go under the radar, but eventually they assemble the market power. And that's why the hospital doesn't have any anesthesiologist practices to choose among.
Right.
Okay, thank you very much. With that, we'll close this session because we are getting late for the next one. Thank you to the panelists.